it will be a pleasure for me to introduce three teams for which I have a lot of respect. So now we're switching. Again, we heard many times today that we have to work together. So now those teams have developed the how we do it. And I have a lot of respect for those teams, for all of the teams here that trying to change the healthcare, because we know it's difficult. I have a few years of experience in quality improvement, and it's really challenging. And yesterday we heard all the challenges just to add a chair in a triage room. So can you imagine changing an entire team, changing an entire system, an entire program? So all the energy it takes. And you are successful in doing it. And concretely, we're going to hear about three teams. First, we will hear from Dr. Jean Bourbeau, who devoted 15 years of developing and disseminating the Living Well with COPD program. He is the director of the Respiratory unit at the Montreal Chest Institute of the MUHC. He leads the COPD axis of the Respiratory network of the FRSQ, and is president of the Canadian Thoracic Society. He's here today with Madame Jocelyne Godard, who lives with COPD, and can tell us firsthand about the benefits of that collaborative model. We will then hear about a complementary COPD program spearheaded by Dr. Graham Rocker, head of the Division of Respirology of Capitol Health in Halifax. His concerns over the poor quality of care received by people with advanced COPD led him to initiate an interdisciplinary hospital-to-home model called Inspired, which is now gaining traction across the country. And finally, we'll hear about the project that involves patients with diabetes in the care improvement project that will be done by Dr. Brigitte Vachon. She's assistant professor at the University of Montreal, and with Dr. Jean Rodrigue, Director of Public Health at the Agence of Montreal. They initiated the program called COMPASS, which is a project to improve health professionals' ability to manage chronic disease. They turn to patients to find out how service offering could be better adapted to help manage their diabetes. So welcome to Dr. Jean Bourbeau and Madame Godard. Thank you.
I guess we should start with the habit of having the patient first, since the patient is at the center of our care. Then, we're going to start with Mrs. Godard's testimony. She's gonna speak in French, but I'm sure for those who only speak English, you're going to be able to read all the emotion that she's gonna have. Madame Godard, merci d'être venue vous joindre à nous. Mrs. Godard has a disease that we call COPD, chronic obstructive pulmonary disease. This is an umbrella term for those that are less familiar to the disease that we call chronic bronchitis and emphysema. Then people don't look sick, by the way, until you see them walking or if they wear oxygen. Madame Godard.
Ça se peut que j'ai un grand trémolo. Alors, mon nom est Jocelyne Godard. J'ai été diagnostiquée ayant une maladie chronique en 2007. Depuis ce temps-là, je suis patiente à l'Institut thoracique de Montréal et je fais de l'emphysème à un stade qu'on qualifie de sévère. Mais, comme on dit, c'est une maladie un petit peu, je vous dirais, c'est invisible. Parce que quand je travaillais, j'étais assise à mon bureau, il n'y a pas personne qui savait que j'étais malade, mais j'avais de la misère à faire mes journées. Donc, en 2007, je travaillais très fort, j'avais une belle vie, je voyageais et tout ça, et après, ça s'est dégradé. Alors, lors d'un suivi médical, toujours à l'Institut thoracique de Montréal, on me parlait de ce programme qui s'appelle « Mieux vivre avec une maladie chronique » ou avec une MPOC. Alors, j'ai pris tout de suite ça. Certain, on va régler ça, check, done, ça va être fait. On va régler ça, puis après, on va pouvoir continuer notre vie. Sauf qu'une maladie chronique, c'est loin d'être comme ça. Et pas juste pour les poumons. Je pense qu'une maladie, en général, c'est pas comme ça. Alors, là, je me doutais pas du tout ce que c'était une maladie chronique, puis encore moins de vivre avec ça. Mais aujourd'hui, je peux vous parler du programme parce que je l'ai fait 3 fois via l'Institut thoracique de Montréal, en raison de 3 jours semaine, 3 demi-journées semaine, et j'ai aussi fait un séjour de 3 semaines au Mont-Sinaï, qui est un programme similaire, je vous dirais, mais beaucoup plus étoffé, vu que c'est sur 3 semaines. Alors, ce que m'a apporté ce programme-là, ou ces programmes, je les ai fait à répétition, mais c'est quand même sur 7 ans. Depuis 2007, là, je l'ai fait 4 fois. En fait, c'est une connaissance, premièrement, de la maladie. C'est quoi exactement qui se passe? Aussi, j'ai appris là, à ma grande surprise, que nous, comme patients, comme individus, comme participants à un programme, on pouvait même faire une différence. C'est sûr qu'une maladie chronique, par définition, je ne peux pas la guérir, mais j'ai pris là des formations, de l'information pour m'aider à me prendre en charge moi-même, finalement, ce qui nous donne un gros avantage sur cette maladie-là. On nous offre des outils très simples, mais très efficaces en ce qui me concerne, comme un plan d'action, où on a à noter nos symptômes et à suivre qu'est-ce qui va se passer. Donc, on peut intervenir ou on peut interagir avec les professionnels et tout ça pour nous aider. Après ça, on a tout le volet là, de ergothérapie, si je peux dire, là, comment conserver l'énergie, ou même en donner, comment s'y prendre. Et tout ça est encadré avec un programme d'exercice physique. Parce que plus on est essoufflé, moins on en fait, puis on a peur d'en faire, on ne veut même plus marcher. Moi, quand je travaillais, là, j'avais une petite carte pour prendre l'ascenseur, puis je me cachais pour prendre l'ascenseur parce que je voulais surtout pas qu'on voit que j'étais diminuée, mais j'étais quand même pas mal diminuée, du moins physiquement. Puis avec le temps, je vous avoue que le moral, il en prend un coup. Donc, dans ce programme-là aussi, on a des échanges avec les professionnels, c'est certain, mais aussi entre patients. Donc, ça m'a fait du bien parce que je me sentais plus toute seule dans ma grande maladie, soi-disant, là. J'ai aussi appris que, les médicaments, si tu les prends à heure fixe, c'est correct, mais c'est beaucoup plus que ça, c'est comment tu les prends. Parce que quand on a un problème pulmonaire, souvent, on a affaire avec des pompes, puis souvent, on les prend peut-être à heure fixe, mais on ne les prend pas comme il faut. Fait que ce programme-là nous renseigne également là-dessus. Comme je vous disais, on travaille beaucoup les échanges entre les gens pour s'aider. Et pour moi, parce que je veux faire ça quand même assez rapide, pour moi, le point majeur ou le point clé, ça a été, moi je l'ai baptisé comme ça, là, mais c'est mon infirmier pivot. C'est-à-dire qu'on a une personne qui intervient, c'est un intermédiaire, un trait d'union, je sais. Moi, je l'ai appelé le pivot entre le spécialiste, donc le pneumologue, et pas juste le pneumologue, tous les autres intervenants. L'ergothérapeute, le nutritionniste, nommez-les, le travailleur social. Fait que si on a des questions aussi, nous, ça nous met... on est moins gênés que de faire affaire avec tous ces gens-là, mais les réponses, c'est des gens disponibles et surtout, ils suivent notre plan d'action. Lorsqu'on ne va pas bien, il y a un processus là, qui enclenche ça, puis eux, ils nous suivent, ils nous rappellent et tout ça, ils nous soutiennent. Fait que voilà, c'est à peu près ça ce que j'ai retenu de ce programme-là. Par contre, ce que le programme m'a demandé, par exemple, mon implication, un petit brin de discipline, parce qu'il faut quand même être constant dans ce qu'on met en application, puis aussi de revenir souvent à la base. Parce que c'est un peu ça le problème, quand on va bien, là, moi, j'étais comme guérie, là, puis on reprend une vie qui était belle, mais qu'il y a d'autres choses quand même qui est beau, là, mais fait qu'il faut revenir à la base. Maintenant, quasi en terminant, je voulais vous parler des bienfaits. C'est à la mode de parler de l'énergie durable, du développement durable. Moi, je veux vous parler des bienfaits durables. Parce que moi, je suis beaucoup plus résistante qu'avant. Avec une capacité moindre pulmonaire, je fais plus. Et même si ma capacité elle descend tranquillement, on le voit par nos tests, mais je suis encore capable de faire des choses, puis des belles choses. J'ai eu moins d'hospitalisation, et ça, c'est majeur, parce qu'avec tout ce qui vient, les tâches connexes de l'hospitalisation, je les ai eues aussi. Moins d'intervention directement aux urgences des hôpitaux. Aussi, ça m'a donné une assez grande confiance avec le plan d'action. Parce qu'au début, on dit « Ah, c'est ça que j'ai pas ça ». Mais à force de tout mettre ça en place et que ces professionnels-là, ils nous confirment qu'on n'est pas si mal ou qui réajustent qu'on a besoin, bien à ce moment-là, ça nous donne une plus grande confiance, d'où de l'autonomie. Puis ça, c'est super important. Puis aussi, moi, dans mon cas, ça m'a créé beaucoup d'espoir parce que je pensais de plus voyager, plus faire de projets. J'étais finie, là, finalement. Mais c'est pas comme ça. C'est sûr qu'il y a des limitations, mais je pense qu'il faut... C'est là qu'on dit mieux vivre avec. C'est là que ça prend tout son sens. Ça m'a donné des meilleures habitudes de vie. À savoir, j'ai intégré à tous les jours de l'exercice. Même mon alimentation a changé. Puis mon chum, il est bien content parce qu'il a maigri de 12 livres. Fait que ça, c'est vraiment important parce que ça donne tout ton entourage, les gens, ils t'appuient. Fait qu'ils te suivent là-dedans. Fait que tout le monde a des meilleures habitudes alimentaires et de vie. Puis aussi, lors d'hospitalisation, parce qu'il y en a encore quelques-unes, lorsqu'on sort de l'hôpital, on est vraiment... comme au neutre, mais j'ai une masse musculaire, vu que je m'en ai occupé tout le temps, un petit peu plus en forme. Donc, je remonte la pente plus vite là-dessus. Fait qu'en conclusion, je vous dirais seulement, je pense qu'il y a 2 Jocelyne, une avant le programme puis une après. Celle avant, quand j'ai été diagnostiquée surtout, je voyais surtout ce que je ne peux plus jamais faire, toutes mes limites, tout le monde dit « Ah, fais des petits deuils », mais il y en a en ciel. Hein. Fait que là, mais après le programme, je peux vous dire que je vois beaucoup plus ce que je peux faire, puis ce que je peux faire encore, puis j'espère pour longtemps. Là-dessus, je vous remercie. Au revoir.
We've started the Living Well about 15 years ago, in fact, and this is not about a piece of material. It's about trying to integrate where in our management, the patient is really at the center of that system. And if you keep that in mind all the time, okay, then everything that you're trying to coordinate, all your communication, then the patient remain really at the center of all of this. And it's challenging. Let's say that it is challenging for the patient. It's challenging for us as healthcare professionals. This is, in fact, what we started in 1997, and a long time ago. I was very naive at the time, and I hope I'm still very naive, because it allowed me to move on where I am now. And if I remain naive, then hopefully I'm going to continue to move on and being open to what the other people are going to say, and I don't have the pretension to know everything, that I can listen to other people on my way. But at the time I was working with a nurse, Deanne No, and those patients were left alone. There was like nothing for these patients. They were taking a piece of this and this from whatever the asthma education for, and trying to fit that in, okay, in a disease that was completely different. And we came to this idea, okay, of developing a program and having a guide to the healthcare professional also, not only a piece of material, a nice picture and what the content should be, but having a guidance that we can give to the healthcare professional how to do that with the patient. And then that's what we have started in 1997, 98, based on a pilot project that we never published at the time. 16 patients were involved and 5 healthcare professionals. Then the temptation at the time was very, very high that this is what a lot of people were asking about this program. And can we say, well, but where are the data to show that this is really effective? We didn't know 15 years ago that that would be so important. Like now we We want to evaluate everything. Okay, we're in an era where resources are really competing, cut after cut. Then we say it's going to be important to have data to show that this is working. But what are we looking for when we say it's working? And we put together a randomized clinical trial. That was in those days, randomized clinical trials were about drug, about things that were really, but about non-pharmacology intervention. That was quite innovative at the time. A lot of challenges, again, that I know now that we're trying to overcome that I didn't know at that time with the non-pharmacology intervention. We were lucky at the time to have the Boehringer Ingelheim, who agreed to support the program development and also to support in part, large part, the randomized clinical trial. Randomized clinical trial cost money. We're talking of a study here of close to $1 million. Okay, this is a lot, okay, of money at the time too. And that was supported by the FRSQ, the Fonds de la Recherche en Santé du Québec at the time. The program is, again, I'm going to go quickly here, but it's about, the center of the program is about patient self-management. Then there is also the design of the system, the decision support, and the clinical information system. Or those that are familiar with the chronic care model, essentially, that's what this program was about 15 years ago. This is the result. Comparing to a control group, what you see here on the main outcome, it's a reduction of 40% of hospital admission. There was 40% reduction also, okay, of emergency room visit and 60% of non-scheduled physician visit compared to the control group. This is a study that one of my students did where we followed with the administrative database from the RAMQ. We look at the first year using the RAMQ database this time, and we also look at the second year. Although these patients were not followed the second year, you can still see an effect, a reduction of close to 30%. And this is quite something when you think that, oh, these self-management were still going on despite the fact that most of these patients were not part of a system at the time, because that was quite new, and there was no such system in place. That was only part of the study. Since we're talking of cut these days, I think we should get this study on the out and more visibility, because what this study shows with a caseload of 50 to 70 patients per case manager, because there was a case manager, what the patient was referring to before, there was a reduction of 1/3 of the cost per year as compared to the control group, which is here then over $2,000 as compared to a baseline cost of $6,000. The cost was now down to $4,000. This is including the salary of the case manager. And obviously, if you want to save money, you have to reduce hospital admission. Then the government buy in this program in 2003 as to now, okay, and the program now is across the province, in many parts in the country also, especially in pulmonary rehab, but also in home services and COPD clinic. Moving, okay, to a new edition, okay, in 2004, 2006. We also got a randomized clinical trial with the home-based rehab program supported by the Canadian Institute of Health Research, showing that you can be as effective if you choose the right patient doing rehab at home as opposed to rehab in hospital or as an outpatient in an hospital setting, and then you can reduce the cost of such program. There hasn't been much of a buy-in since that time. Okay, if that had been a drug, you can imagine that this would have been prescribed and this would have been used since that time. We then move on into a model where now we're testing in the real life, and that's challenging. I know, okay, you referred to that, Alain, before, how challenging it is to have the discipline of doing something and having quality indicator. And I know because of sake of time, I'm going to go quickly on this one, but just to show you that those patients were very sick, and the nurse were asking us over time, we have to spend much more time on our COPD patient. Okay? And we said, okay, let's check that. And that was not to check the nurse, because I always believe my nurse. They've been right more often than have been right. Then for the case manager, I said, okay, let's sample in 2006, and let's sample in 2009. That was in 2009 that they made that comment. Those are random samples in our clinic. They were right that the patient were more sick. And those are not the same patient. They're different 50 patients at each time. And you can see that on the column of 2009, these patients have a lower FEV1 and have a higher rate of exacerbation. This is a huge change in 3 years. Then they were also right that they spend more time. They spend more time on the phone call. Phone call could be the patient calling or then the nurse calling the patient and following the patient. 50% more phone call. Although, good news, they had less visit to the nurse and they had slightly less visit to the respirologist. Interesting. Do we get good result? In terms of the action plan, they were doing better in 2009 than in 2006. Despite these patients being sicker, if you have the right system, and what the patient was saying before, what has helped me the most, it's having the case manager. Having that person that I can call, a person that can call me, that can readjust my treatment, that can answer my question when I'm concerned and so on, that can interact with the physician, interact with the other care professional, and now interact in the community with the other case manager, because we do have now many of these patients that have their case manager in the community, in the CLSC, in the SRAD, soins respiratoires à domicile. And there was a reduction even further of the health services use, hospital admission and emergency room. And exactly what you want, okay, to see. The bottom line now is, do we have enough of these systems in place and where the patient is at the center of our preoccupation and that we're working with that patient and the patient working with us? Because the patient said that also. She engaged, she had homework to do and she was doing it. And we have to bring the patient in that process also. That's a challenge also. It's called motivation. We're now working in primary care. We have adapted the program in primary care, and everything has here to do with the goal of the patient. You have to set goal with the patient, not your goal, the patient goal. The patient is at the center, and that's what the new material is going about. It's about setting goal with, okay, the patient. But we still have a lot to learn in primary care. Don't think that when we have the answer in one setting, that we can necessarily generalize. And it could be a mistake. It could cost a lot of money. And there are now 2 major randomized clinical trials. One that is not even published that I'm putting here forward, going to be published next week or so. These 2 studies were in the Netherlands, where we know that the primary care system is at a very high level. They do have quite nice networking over there. And the 2 studies were negative. They were negative in terms of improving health-related quality of life. And in fact, what we still need to learn is how best to deliver health care that is better integrated and more coherent. That is care based on a strategic alliance between primary and secondary care and support when needed by interdisciplinary team for patients with high risk and complex COPD. Because a lot of the work that we've done so far, and that's my experience with Living Well, and what you're going to see also with Dr. Rocker after, is those are with severe COPD patients. But we have to learn now to work better with patients that are less sick. Then we can have an impact on the long term. I know we don't like that. We don't like that because we're going to have to wait much longer to see the result. This is sort of the Kaiser model that they're proposing, and I'm done, promise. And I like Roche presentation, it's about disease stratification. Now we have to learn how to do that. But if we can learn at least how to do that, we're going to be able, okay, to come with a model where we have a better strategic alliance, and we're going to be able to divide the care such a way that we're going to put the team where it is valuable to put the team, because we're going to have to be selective on our resources. There is no such way, even after getting rid of the health agency, all the decision maker, all the doctor, all the nurses, they're still going to have a cost because of the aging of the population and those damn chronic diseases that we're all going to have at some point. We just don't know which one and when we're going to have that disease. That's the only thing, okay, that we don't know. And I'm going to end by acknowledging a lot of people, and my sponsor, obviously, that have been from the public to the private. I wouldn't be able to have done this without the industry, by the way. I don't know where Mrs. Roche is. Okay, then my question, I'm very tough on the industry, but, you know, I need you. But I also need the patient, okay, and thanks to all the COPD patients.